A production fee for your Hometown Health Connection was made by Buffalo Healthy Living Magazine and its sponsors.
While October has been designated as Breast Cancer Awareness Month, it is an issue for women and men that is important to be aware of all year long. Why? Look at these stats. According to breastcancer.org, about 1 in 8 women in the U.S. will develop invasive breast cancer over the course of their lifetime, and about 45,000 women in the U.S. are expected to die from breast cancer this year. While death rates have been steady in women under 50 since 2007, they have dropped in women over 50, thought to be the result of treatment advances and earlier detection through screening. On this edition of your Hometown Health Connection, we'll meet a hometown expert on breast cancer with information that could save your life. I am Kate Glaser. Welcome to the program. Joining us is Dr. Stuti Tambar. Dr. Tambar earned both her undergraduate and Doctor of Medicine degrees from the University of Buffalo, where she also completed her residency in the General Surgery Training Program. She completed her training with a specialization in treating malignant and benign breast disease from Georgetown University and focuses on screening and identifying high-risk patients who will benefit from surveillance. She is a fellow of the American College of Surgeons, a member of the American Society of Breast Surgeons, a recipient of the SMBS Naughton Award for Service, and a member of the Golden Key Honor Society. Dr. Tambar has numerous publications, and when she's not at work, she loves spending time with her husband and 3 children, cooking and running. Wow, you are so busy, Dr. Tambar. Thank you for joining us.
Thank you so much for having me on today.
Absolutely. So what is the most important thing that you want women watching to know about early detection, and how and why that saves lives?
So the early detection of breast cancer is the most common reason that we are seeing patients who are diagnosed with 2 millimeter, 3 millimeter cancers who need minimum small surgery and quick treatments to finish their treatment plan. And we're adding to the surviving women with breast cancer. Late detection generally leads to higher staging, more aggressive breast cancer potentially, and needing more aggressive treatments. So we are just seeing better and better outcomes with early detection.
So early detection versus late detection, what is the difference? I mean, I know that you said there's a difference in stages. How does someone know they're in early detection versus late detection?
So the staging or locally advanced disease, as is identified usually in late stages, is the disease has already progressed on to their lymph nodes, and they generally require more aggressive chemotherapy, more aggressive treatment in general. But an early detected breast cancer, most women can skip chemotherapy, and it will be just a surgery and follow-up treatment that will finish off their treatment plan, and patients don't need any further treatments.
Can you talk about the importance of breast self-exams here too, in its role in early detection?
Self-breast exam is extremely important in that women perform it every month. We have seen so many patients who detect a lump in their breast between their screening mammograms, which is generally done once a year. Women younger than 40 who don't even qualify for screening mammograms find lumps on their own on self-breast exams. So it's extremely important that women know how to perform a breast exam and what to look for when they're performing it.
So walk us through that. What should they be looking for? How does that actually work? And you said women under 40 should still be examining even though they're not going in for an actual exam in office. So they should be examining themselves. Can you walk us through how that kind of works and what you should be doing?
Sure. For the self-breast exam, women need to know the landmarks, the boundaries of each breast, which starts all the way up from the clavicle, the bone up in the chest, down to the fold of the breast, from the midline and to the beginning of the armpit. Those are the 4 borders of a breast, and women need to examine every inch of that area. They should be watching for any changes in the skin, any nipple discharge, and make sure that any new findings like a new lump, a bump, a skin change that's not getting better despite treatment, a nipple discharge that is spontaneous, as in appears on its own and women are not doing anything to express it, are notified and followed up with their medical professional. so that they can be worked up and make sure they don't have breast cancer. There's also lymph node swelling in the armpit, which is extremely important. Women check on and make sure that if those are found, also need to be worked up.
How often should they be checking themselves? Is it once a month? Is it something where they should be concerned if something pops up and call their doctor right away? What do you recommend?
Absolutely. It's very important that it's checked every month. And it's for premenopausal women who are still having their periods, the optimal time is about a week to 10 days after they start their periods. And for postmenopausal women, they can really pick any day on the calendar since there's really no hormonal surges throughout the month. If any suspicious findings, they should notify their primary care or gynecologist and make sure that it's worked up right away.
Wonderful. Is there more than one type of breast cancer?
There are multiple types of tissue that make up a breast, so women do have risk of developing any of those cancers. The most common breast cancer, however, is of the milk duct. About 80% of all breast cancer are of milk duct.
And can you talk more about staging and what that means and what the importance of staging is?
Staging of breast cancer depends on the size of the actual tumor. If the cancer has already progressed to the lymph node, or if it's progressed anywhere beyond lymph nodes like the liver or the bones. Staging of more aggressive cancer is higher compared to their not so aggressive counterpart. For example, the size to size, a tumor which is highly aggressive, which we staged higher. And staging of the breast cancer directly correlates to the prognosis of the patient. And those patients with higher staging end up needing more aggressive treatment also, like chemotherapy, extensive radiation, and probably extensive surgery also.
Okay, and let's talk about genetics and ethnicity as well. What role does that play in breast cancer, and who and what type of groups are most at risk for this?
So overall, Caucasian female are at highest risk for developing breast cancer, but the research and surveys have also shown that African American females are at higher risk of developing more aggressive cancer and presenting with a higher stage of breast cancer. They also have the higher risk of mortality from breast cancer. So genetics does play a good role. Any first degree relative with breast cancer doubles a woman's risk of having breast cancer. So parents, siblings, children, anybody with breast cancer will significantly increase their risk. Also, only 5 to 10% of all breast cancers are actually linked to genetic mutations. 85% are actually brand new. Women do not furnish any family history in those cases. Ashkenazi Jew have the highest risk of having breast cancer because they have the highest prevalence of BRCA mutation. So those are some of the statistics that are known in breast cancer.
Okay, I actually have a friend who is diagnosed with a very aggressive breast cancer. She's only 32. I thought that was abnormal. What is the average age of women who are diagnosed with breast cancer?
The average age is 55 to about 64, with 62 being the median age, but we are diagnosing cancer younger and younger. My youngest patient at this point is 29. So we are finding these women very young, and it's surprising because these women don't even qualify for screening until the age of 40. They have no family history, nothing to indicate that they were higher risk, yet they are presenting with breast cancer. That's why self-breast exam is very important. Almost all of these women present after palpating a mass, a lump themselves.
And the one thing that she said that I've always noted is that she didn't really think she had an issue. She felt a little bit of a lump, and then she actually went in because her mom told her to. It was a small lump, and then she had that aggressive breast cancer. So it's so important, like you said, to have that self-exam. So important. Can you talk about what we are learning about different age groups and what screening should begin to get mammograms and how often women should go in for a mammogram?
So the first thing extremely important is for women to know what's their risk of breast cancer. Average risk women who have no personal or family history or risk factors of breast cancer should start screening at the age of 40, which should continue every year, once a year. For women who are high risk based on personal or family factors, they should start screening as early as 25 if they have genetic mutation, or 35 if they don't have genetic mutation. And they also qualify for a breast MRI annually in addition to mammogram.
All right, and let's talk about the 2D versus 3D mammograms. MRIs, ultrasounds, any other imaging methods that are used to detect breast cancer. Give us more knowledge on what you are looking into for that.
So currently, the most common used technology for screening breast cancer is mammogram, ultrasounds. These are the screening tools we use on all average risk women. Women who have denser breast can add an ultrasound because the sensitivity of mammogram is a bit lower on those patients. But for postmenopausal women who don't have dense breasts, just a screening mammogram is enough. 3D mammogram has become a standard at this point for breast exam, and it basically takes multiple shots of the breast. Imagine taking 2 shots of the breast in compression, sideways and top, versus taking multiple shots all around the breast. So 3D has become a new standard, and 2Ds are basically being phased out at this point.
Are there any new imaging technologies currently under development that you know of?
There are a couple of new technology. There's positron emission mammography, which is basically like a PET scan where a sugar-based dye is injected, and any cancer cells are detected using a scan. This is still in the works, not really mainstream at this point, but this will be focused on just the breast. Something that's more upcoming is contrast enhanced mammogram, where an iodine contrast is injected just prior to a standard mammogram, and that enhances the breast tissue, and radiologists are able to identify even smaller, lightly abnormal mammograms.
Many women are scared of mammograms because they hurt, or at least what I've heard. I've never had one myself because I am in that 30 age group, but talk about why women, even though it may cause some pain, why it's so important, like you said, to either have that detection and self-screening or go in for a mammogram.
So usually it's not either or. Women should examine themselves and undergo screening mammograms every year. It's extremely important. I have had multiple myself. I'm in that 40 age group. So it's once a year. A lot of women I know, they have their friends who all go together to have their mammogram, and have had lunch afterward. It's like their little annual retreat. So this extremely important. It's slightly painful, it is, but it's not something that should be prohibitive. It's just a simple test.
I love that you said that women should make this sort of an annual trip where they go with their girlfriends, they have lunch. That's so, so important, because it's not just enjoyable. It gets you through that anxiety of going in for a mammogram. I love that. Thank you so much. We will return to continue the conversation on breast cancer in just a minute. Here is another stat. Breast cancer became the most common cancer globally as of 2021, accounting for 12% of all new annual cancer cases worldwide, according to the World Health Organization. We will continue the conversation in a moment. If you would like to reach out to Dr. Tambar, connect with the Great Lakes Cancer Care Collaborative online at greatlakescancercare.org and click Find a Doctor, or by calling 716-884-3000. Write that information down and reach out if you need to get checked or need cancer care. We will be back in just a moment.
Buffalo Healthy Living magazine is a free, full-color magazine distributed throughout Western New York. Now, more than ever, as we all want our families and friends to be safe and well, Buffalo Healthy Living magazine is devoted to health, fitness, and nutrition for people of all ages. It's a great read and also has great recipes. Pick up Buffalo Healthy Living magazine all over our hometown, or go online anytime at buffalohealthyliving.com.
Welcome back to your Hometown Health Connection. I am Kate Glaser. We are continuing our important conversation about breast cancer with Dr. Stuti Tambar. So, Dr. Tambar, how common is breast cancer? Let's talk about that. Everyone talks about it in the month of October, but how common is breast cancer?
So breast cancer in this year, 2021, is now the most common breast cancer in North America and globally. 1 in 8 women will be diagnosed with breast cancer, and this year is estimated about 280,000 women will be diagnosed with invasive cancer, and over 45,000 will be diagnosed with a non-invasive form of breast cancer. About 2,500 males will be diagnosed, and unfortunately, over 40,000 women are estimated to not survive their diagnosis. Um, Breast cancer rate is one of the highest cancer rates, just after lung cancer. And the upside part is it's becoming very curable, very treatable, and we have 3.8 million women at this time who are breast cancer survivors. So what we hit earlier in the segment, the early detection, appropriate treatment, those are the key to adding more to those survivors.
Invasive versus invasive, correct? Invasive versus invasive. Talk about that as well and what the difference is between those two categories.
So it's invasive versus non-invasive breast cancer. Non-invasive breast cancer does not have the capability to go outside of the breast. It can locally grow and can continue to grow on, but it does not know how to travel. So the treatment for those are a little bit limited. Most women don't need chemo, just surgery, radiation. But the invasive cancer does has the knowledge and tendency to travel, and it will, if given enough time, travel into the lymph nodes and beyond into the bone and liver. So that's the key difference between the two.
Okay, and you did talk about men getting breast cancer. That's somewhat of a misconception. Some men don't believe, or maybe some people don't believe, that men can have breast cancer. So talk more about that. And I know it's a lower number, but it's still important to know about that.
Yes, it's very important for men to examine themselves too, because there's really no screening exam for men in terms of breast. So it's very important for men to be aware and examine themselves again on a monthly basis. It's not common, as you said, as we discussed, only 2,500 versus 280,000 women will be diagnosed with breast cancer. But I personally have treated 4 male breast cancer in my very short career so far. So it's not unknown, it's not rare, but it's certainly thankfully less common. But it's very important still for men to be treated. And these men who are diagnosed with breast cancer, they have 50% chance of having a genetic mutation as opposed to 5 to 10% of women.
Okay, and what should men be looking for when they do that self-exam?
For most common symptom that men will present with is a lump right behind the nipple. That's where, if any, all of the breast tissue is located, and that's where the breast cancer is. So it's very important just to be aware, and if any changes happen month to month, to keep an eye on it, inform their primary providers, and get worked up.
You're so passionate. You can feel just how passionate you are for your career and saving lives here in Western New York. Can you tell us about a success story of a patient diagnosed early who is now in remission? Does anything come to mind that you could tell us about?
There are just so many. Thankfully, we are doing great in this town in terms of early detection. I have patients who are in their 60s, 70s, going through annual mammograms, and the smallest cancer was 2 millimeters. You couldn't feel it, couldn't see it, only found on the mammogram. Took out just a small area of the breast, and the patient received radiation, and they were done. They just received an endocrine treatment, which involves taking a pill every day to reduce their recurrence. So it's a very scary diagnosis when patients first receive it, to know they have breast cancer. But once we get them through the information and what the treatment actually entails, I think it already starts to put them at ease that they're not going to die from this. They're going to survive this. So we have to keep moving along with that, for all patients and all population to know that ignorance and not knowing what their breast has is not going to help, but to know, to empower themselves with knowledge and examine themselves, go for screening mammogram. That's what's truly is going to save lives.
Absolutely. Does everyone diagnosed with breast cancer need chemo or radiation?
Not everybody needs chemo, even radiation. Depends on the type of cancer and the type of surgery they end up going through. More aggressive cancer that have gone into the lymph nodes do end up requiring chemotherapy. And if the women have mastectomy, which is removing the entire breast, they can generally skip radiation. Um, we rarely do recommend mastectomy on specific patient depending on the tumor size, location, if there's more than one tumor in the same breast. But for the most part, pretty much all women do qualify for just lumpectomy, which is removing just a small area of cancer and not the entire breast.
When would a double mastectomy kind of come into play? I've heard of women going for that as well, even as a preventative. So when does that also come into play?
So preventative mastectomies at this time are an option for women who have genetic mutation, more specifically the BRCA1 and BRCA2 mutations. Those are the only two women who currently qualify for a prophylactic or preventative mastectomies, because that's the only group that has shown to have benefit from removing breasts without having a cancer diagnosis. The rest of the population, even with high risk, we don't offer preventative mastectomies. For women who have genetic mutation, those are the ones that would need it.
Okay. Is there any ongoing research right now on breast cancer that you are excited about? And if so, can you talk more about that?
There's so much going on in breast cancer world research, just because of the generous donation in every state, every country. The one that we are looking at is always de-escalation of treatment and how safe that is for women. Make sure that we are not compromising their survival by reducing treatment. Just by example, all women several decades ago would have all of their lymph nodes removed from their armpit with a diagnosis of cancer. But with research, it was shown they don't need to do that because they have a lot of side effects. We can just remove 2 or 3 lymph nodes and make sure they don't have a lot of cancer and give them chemo. So we have more de-escalation treatment currently going on in terms of, do we need to give everybody chemo who have a certain type of cancer? There's also current research going on cryoablation, which is freezing breast cancer, of course, low risk cancer in older population with lower risk of recurrence. So those are some of the research that are currently heading, and we're very excited.
That's wonderful to hear about. You said you've been in your career for a short while, but I'm sure there's been so much growth since then. And then how far has breast cancer research and surgery techniques advanced over the years, just to kind of give us a picture into that?
Absolutely. I mean, just the surgical world has improved so much. We do nipple sparing mastectomy now, which is instead of removing the nipple, all of the skin, we actually save the nipple and put in the implant right behind it to make the breast again. So women have their own nipple, their own skin, their own breast, and instead of having the breast tissue, they have implant behind it, or even their own tissue. So reconstruction involves moving their own fat around to create the breast, like their fat from the back or the fat from the belly, to make the breast. In addition, the complications of surgery have gone down so much. For women who had to remove their lymph nodes because of extensive disease, they used to have 40% risk of having lymphedema, which is swelling of the arm. But with improved techniques, that risk has now come down to 20%. If not even lower, depending on the technique. So we are making strides of advances in even breast surgery alone.
That's wonderful. Great Lakes Cancer Care Collaborative brings together 10 different providers and organizations to provide patients with the best possible care. Can you talk to us a bit about the advantage of being part of a collaborative of providers that work with you in addressing all types of cancer, especially breast cancer?
Sure. Collaborative always provides a patient-centered care. It guarantees a cutting-edge, most effective treatment that's out there. It improves convenience for the patients because everything goes seamless from one treatment to the next. It also provides psychosocial care like physical therapy, nutrition, counseling service, financial assistance, because the resources are maximized by having a collaborative in place, and it's really have been shown to improve outcomes in general. Women and really all population needs to take charge and make sure if they are getting treatment for any cancer, any disease site, that they are part of a collaborative, so that they can maximize their treatment and maximize their survival. So it's extremely important that all cancer patients, all cancer are treated within a collaborative.
Wonderful. Doctor, why did you decide to get into breast cancer, treating patients with breast cancer, getting into this field of work? Like I said, you're very passionate about it. You know so much. Why did you decide to make this your living and your career?
I came from a family where women's health wasn't a very big priority, so I wanted to make it my priority. I wanted to make sure women are empowered, that they are taken care of. When I thought I might want to become a gynecologist, but the world of surgery was just too attractive for me to give up. So when I did breast surgery rotations, I realized that's my passion. I love working with women. I love taking care of them. Breast cancer is such a curable, such a treatable disease that the outcomes are great. So that was so many reasons to go into breast surgery, and it really is my passion at this time.
You said the word empower, which I love. And how are you providing women empowerment and hope? I mean, really, you said that it's a very treatable disease. So how are you walking in and providing that empowerment and hope that so many Western New Yorkers need when they hear the phrase that you have cancer?
I think knowledge is how you empower yourself. And any patient that walks through the door, they are given knowledge about their cancer specifically, not a general knowledge about cancer, but what they have and what they need to make sure they are treated appropriately and they have the best outcome. So early detection, high-risk surveillance, genetic testing, we offer that for all of the Western Europe females and males to make sure that they have the best care.
And you said even your youngest patient was in her 20s, and just to be able to walk in and provide her hope, how does that make you feel to be able to do that, especially for someone who is in their 20s, has their whole life ahead of them?
Those are the patients that definitely need the maximum support because they may need fertility counseling. They may not have children and they may want to have them in the future. So having fertility counseling, getting their embryos frozen, make sure that they are taken care of in terms of treatment and even surveillance after they finish treatment, and really for life, because these women will never have a 0% risk of recurrence no matter what we do. So we need to keep a close eye on these women for their entire life. And even my patients who move around the country, I make sure that they are taken care of in the next town that they're moving through the contacts, and we make sure they have those connections already set before they leave.
Well, thank you, Dr. Tambar, for answering these important questions about breast cancer. It was so good to learn from you and just hear more about why you're so passionate. It was a privilege to talk to you. Thank you again.
Thank you so much for having me on today.
I am Kate Glaser. Breast cancer has impacted so many of us. Make sure you get checked. If you would like to reach out to Dr. Tambar, connect with the Great Lakes Cancer Care Collaborative online at greatlakescancercare.org and click Find a Doctor, or by calling 716-884-3000. Write that information down and reach out if you need to get checked or need cancer care. Stay safe and be well.
A production fee for the preceding presentation of Your Hometown Health Connection was made by Buffalo Healthy Living Magazine and its sponsors.